Okay, welcome to the SADS Foundation's Living with SADS webinar. Today's topic is family planning with an inherited arrhythmia. I'm Marcia Baker, the program director for the SADS Foundation, and thank you for joining us tonight. Our presenter for this webinar is Laura Rust. Laura is a licensed and certified genetic counselor in the Department of Clinical Genomics at the Mayo Clinic in Rochester, Minnesota. She completed her master's in genetic counseling at the University of Wisconsin-Madison. Laura joined the Mayo Clinic clinical genomics staff in June of 2015, so 9 years ago, and supports the Division of Reproductive Genetics and the Inpatient Genetic Counseling Service in the Neonatal Intensive Care Unit. Following Laura's presentation, you may ask questions by typing them into the chat, and we'll try to address as many of those written questions as we can. This webinar is being recorded, so please mute yourself during the presentation and the Q&A session. Now, the link will be sent for the recording a few days to all of you who have registered. So thank you, and I will turn this over to Laura. Thank you, Laura, for being here.
Thank you. Thank you so much, Marcia, for that introduction and for inviting me to speak at this webinar. As Marcia said, I'm Laura. I'm a genetic counselor at Mayo Clinic, and I'm happy to be sharing a little bit about family planning in inherited arrhythmias. My specialty in genetic counseling is mainly on the reproductive genetics side. So this is a topic that I love talking about. My plan for today is to go through a couple of things, just reviewing the importance of preconception family planning in inherited arrhythmia syndromes. We'll talk a little bit about some of the family planning options that would be available to somebody with an inherited arrhythmia. And then some answers to some commonly asked questions that the team here was so kind to pass along ahead of time. And then we'll have some time for Q&A. So first topic, the importance of family planning in hereditary arrhythmias, just some things to consider as one would think about growing their family. Generally, pregnancy is safe in inherited arrhythmias. There's no type of inherited arrhythmia that would be a contraindication to pregnancy or for somebody to say you should not become pregnant at all. However, pregnancy in general is a period of increased cardiovascular risk in a woman's life. So for somebody with an underlying cardiac condition, there might be certain risk factors to consider or reasons why we would want to identify somebody that might be at a higher risk for a cardiac event during a pregnancy or labor or postpartum. This ideally is considered as part of that preconception counseling visit and meeting with different specialists to talk about what does that look like as you consider growing a family. The other thing to consider is most inherited arrhythmias have an autosomal dominant pattern of inheritance. We have 2 copies of every single gene, one from each biological parent. And in inherited arrhythmias, most of those are ones in which one mutation or one copy of that gene having a mutation in it is enough to put somebody at an increased risk for these cardiac events in their lifetime. Since we have those 2 copies, though, there's either a 50% chance that the normal copy gets passed on or 50% chance that the copy with the mutation gets passed on. So offspring are at a 50% chance of inheriting this condition from an affected parent. So that's also something to be considering is risk to a future child. When we think about some of these complications, there can be risks both to the pregnant person as well as the fetus or the future child. Pregnancy is accompanied by a variety of changes that can provoke new or exacerbate previously occurring arrhythmias. For the most part, there's not really a difference in the rates of cardiac events during pregnancy, but sometimes there is a little bit higher chance of these events in the postpartum period. So kind of considering this whole like perinatal spectrum from preconception to post-delivery and lactation is really important. certain diagnoses do have higher risks of complications, especially during the labor and delivery process. So this table is from a paper that put different diagnoses into different risk categories, and then stratifying those different risks of like what kind of surveillance would be important to consider during pregnancy, during the laboring process. What are things that that team should be aware of? And this would be something to make sure that like the obstetric team that would be caring for somebody with an inherited arrhythmia is aware of, and that there's kind of this multidisciplinary approach with the cardiology team and obstetric teams and neonatology teams. Other possible complications, there are some reports of a slightly higher chance of stillbirth, so a second or third trimester pregnancy loss. Specifically, this has been reported in long QT syndrome, but not necessarily in some of the other inherited arrhythmias. Overall, that absolute risk is still pretty low. In one paper, that risk of stillbirth was 4%, compared to about 0.5% in the general population. This was a relatively small study, and so it's possible that that could be an overestimate or just based on this one study, but it certainly has been reported. I put a question mark by SIDS, the sudden infant death syndrome. There was an Italian study that found a higher rate of mutations in inherited arrhythmia genes in stillbirth cases, although it seemed from this study the majority of those were families where there wasn't really a known family history, and maybe these were new mutations that occurred in a child. That would have potentially led to that sudden infant death syndrome, but nonetheless, it's, I think, any sort of condition that does have a risk of sudden death is something to be aware of and thinking about for future kids. The other thing is sometimes we can see fetal arrhythmias in pregnancy. And so how would that be something that's managed by an obstetric team? What would be a plan for ultrasound surveillance and things like that? Generally, fetal arrhythmias are benign in nature, but there are some that can lead to significant complications, resulting in maybe early delivery, premature delivery, or even stillbirth. Something that would be important for like the obstetric team to consider in this planning for a pregnancy for a patient with an inherited arrhythmia are some of the recommendations that come from a guide from the 2023 Heart Rhythm Society guidance on management of arrhythmias during pregnancy. I think there's 10 or 12 points in this specific documentation. A lot of them are referring to the importance of that multidisciplinary management, specifically including the cardiology team, one that specializes in arrhythmia syndromes, the obstetric team, maternal fetal medicine, which is going to be your high-risk pregnancy doctors, genetics, neonatology, and any other specialists that might need to be involved in the care of a pregnant patient and their child. There's recommendations for a full physical exam, kind of baseline, how is somebody's health prior to pregnancy, getting an updated EKG prior to pregnancy, recommendations for genetic counseling and options for testing. If that's not something that's been completed prior to a pregnancy, having that information available to be able to offer testing to a future child would be really important. A review of the medications. Most medications that somebody would take for an inherited arrhythmia are actually safe during pregnancy. Some have no studies, but for the most part, the recommendations are to have the same medications you would when you're not pregnant. Pregnant patients should not have their beta blockers changed without any sort of guidance, unless it's from a SADS expert. So, I think it's important to at least address those medications, but also to make sure that the obstetric team is aware that no changes should be made unless that recommendation is coming from the cardiology team. There's recommendations for what to do if cardioversion or defibrillation or cardiac life support are needed. Honestly, these are mostly the same as it normally would be, but there are some notes about what it would look like, if for CPR, for example, if might be a little bit different in a pregnant person that's in the third trimester that has a larger belly at that time. And then addressing delivery recommendations, and truly there's no reason for somebody who has an inherited arrhythmia to have a C-section just because of that. Vaginal delivery is perfectly safe and okay. But again, it's sort of, making sure that everybody is on board and everyone is aware of these recommendations as somebody would approach that pregnancy, and finding a care team that's comfortable managing a pregnancy. The International Journal of Cardiology and Congenital Heart Disease also has some different recommendations. This sort of breaks it down by different diagnosis and what's involved in the prenatal counseling, general recommendations for pregnancy, medications, labor, and then that post-delivery care. So just some different references that would be important for that obstetric team to be aware of. But, I think a common theme in all of these different recommendations is the importance of planning for pregnancy ahead of time, and having both the patient and the medical team as prepared as possible. There's other family planning items to consider totally separate from an inherited arrhythmia syndrome. These are general family planning recommendations, the things that probably everybody should consider. Things like reviewing a medical, surgical, psychiatric, social history, other medications. So things unrelated to inherited arrhythmias. There might be other diagnoses that somebody has that also need to be reviewed. Optimizing a healthy lifestyle prior to pregnancy, maintaining a healthy diet, reducing smoking, heavy alcohol consumption, heavy caffeine consumption, recreational drug use, things like that to make sure that fertility is optimal, but also things that might be risky early in a pregnancy are minimized. Recommendations for taking prenatal vitamins, specifically those with folic acid. Folic acid is proven to reduce the rates of birth defects in pregnancies. So currently recommendations are for starting prenatal vitamins even prior to pregnancy. In the United States, over half of pregnancies are unintended or unplanned. And so that really is a recommendation that people of reproductive age, specifically women of reproductive age, should be taking prenatal vitamins, even if they're maybe not trying to get pregnant. Understanding the fertility and ovulation window, what point in the menstrual cycle is somebody ovulating? What are some of the age-related risks? Unfortunately, as females' age increases, we know that fertility decreases, the chance of conceiving with each menstrual cycle decreases, but also the risk of pregnancy complications increases with age. The other, from a genetic standpoint, the other important thing is screening for autosomal recessive conditions with a childhood onset. Carrier screening is something that's offered universally to anyone who is considering starting a family. These are different genetic conditions. These are things that might not actually be in a family history. Conditions that follow a recessive pattern of inheritance for somebody who has just one mutation in a specific gene actually is not going to have signs and symptoms like they would in an inherited arrhythmia syndrome, like lung QT syndrome. For example, cystic fibrosis, which is a chronic lung disease, or certain forms of muscular dystrophy, or sickle cell disease, or metabolic conditions, lots and lots of different childhood onset conditions have this recessive pattern of inheritance. And you could be walking around with genetic changes in these genes and never know it. Carriers are asymptomatic, and carriers usually have no family history of these conditions. The only thing we really worry about for somebody who is a carrier of a recessive condition is if both reproductive partners are carriers of the same thing. Every pregnancy that couple has together would have a 25% chance of having whatever serious childhood onset condition that is. And around 2 to 3% of couples are carriers of the same thing. And so this is a tool that can be used to make sure there's not a totally different genetic risk factor that we would want to be thinking of, or potentially would change somebody's plans in how they decide to grow their family. Being up to date on things like pap smears, sexually transmitted infection screening, and other immunizations. Thinking about contraception options, what's the best option for you based on kind of your lifestyle, your health history, and things like that. And then also considering things like travel recommendations. People might remember, gosh, probably 6 or 7 years ago with the Zika virus, and that was causing an increased rate of birth defects in pregnancy. And so there were recommendations to avoid travel to certain parts of the world if you were trying to get pregnant. And so just being aware of those types of things as well. Switching gears a little bit here, thinking about what are some of the options as you decide to grow a family. How are the ways that somebody might get pregnant, and what are some of the genetic testing options that would be available for those people? Um, so thinking kind of along the lines of spontaneous conception, this is of course the cheapest way to get pregnant, and sometimes the fastest way would just be spontaneous conception without any sort of fertility treatments or IVF or anything like that. For people who do conceive spontaneously, they might be interested in doing genetic testing to find out if the baby is affected, and there are different points in time when that testing can be done. During a pregnancy, a chorionic villi sampling, which is a biopsy of the placenta, can be done usually around 12 or 13 weeks of a pregnancy. A sample of the placenta can be sent off for genetic testing. Alternatively, amniocentesis, which is what this picture is showing here, can be done a little bit later on, maybe 15, 16 weeks, really anytime after that in a pregnancy. And that's where a sample of amniotic fluid that surrounds the baby is collected, and that fluid is sent off for genetic testing. Both procedures do carry a small amount of risk of complications, including a small chance of miscarriage. And so, it's sort of weighing the risk benefit of finding out this information during the pregnancy. Did that fetus inherit that genetic mutation from a parent or not? In some ways, it may guide that pregnancy and delivery management, and certainly would guide the care postnatally of how that baby is cared for. But couples definitely have to decide if they want that information during the pregnancy at the very small risk of a complication. If for people that go this route, genetic test results, it can really vary depending on the lab that's used and if other testing is being performed. Results can take anywhere from a couple of weeks, maybe up to 6 or more weeks in certain cases. But again, it can be useful in that pregnancy and delivery management. For some people, testing during the pregnancy is maybe not in line with what their plans are. Maybe they're okay with waiting until after delivery. In those cases, if we can, we would plan for something like collecting umbilical cord blood at delivery, and doing the genetic testing on the cord blood. Or if that's not possible, sometimes logistically it's not possible to obtain umbilical cord blood, a baby's blood can be drawn sometime after they're born, and the testing can be done at that point to find out if they inherited that mutation or not. For some people, they're interested in options for reducing the risk of passing on a mutation to their children. And there's a lot of different ways to do that. For some people, they decide not to have biological children. Maybe they choose to grow their family through fostering or adoption, or maybe just choose not to have children, so that the mutation is not passed on. For other people, they might consider using a gamete donor, which is an egg or a sperm donor, depending on which parent has the diagnosis. There's also what's called embryo adoption, where you can still carry a pregnancy, but this is an embryo from another couple who's completed their family and has leftover embryos that they are not going to transfer. That there are options for embryo adoption. For people that want to have biologically related children to both partners, one option might be doing in vitro fertilization, or IVF, with pre-implantation genetic testing for monogenic disease, or PGTM for short. PGTM is a test that is done on embryos that are created through IVF. The test that's done is specifically designed for that specific couple. It's unique to their genetics. That test that's designed could not be used for anyone else in the whole world, even other family members with the exact same mutation. To design this test, there are a lot of steps involved. It can take a long time to design this really specific test, and sometimes there's DNA that's requested from other family members to help make that testing more robust. This is sort of a very simplified version of the PGTM process. But what these different DNA colors are representing are the 2 copies of whatever gene it is. And then I use the heart to represent the specific genetic change that would lead to the inherited arrhythmia. The middle is the affected parent, the person who's seeking IVF for the purposes of doing the genetic testing. They have this mutation here. The way the test would be designed is that it would be designed to look specifically for this mutation. We know that mutation is there, and so we want to test their embryos for either the presence of that mutation or did they get this other copy, the purple copy of their chromosome, which is the unaffected copy. One of the limitations of doing testing that way is that the technology, while it is very good, it is not perfect. And sometimes we often refer it to as a probe, which is designed to identify that mutation. Sometimes that probe actually doesn't bind the way that it's supposed to. So when the computer reads that result out, it reads a negative result. And that would actually be a false negative result if it was a probe failure. So what the laboratory would do is they would look for other markers to know that this is the green chromosome and not the purple chromosome. But the way that they assign that is by actually testing that person's parents, so technically the grandparents of the embryos, to be able to match those different markers. So that's why often other family members might be involved in this process, which is a big ask to involve somebody in an IVF process. But usually it would be the most robust way to test embryos is to have DNA samples, not only from the mother and the father of the embryos, but also the grandparents of the embryos from the side that has that diagnosis. Most PGTM also includes what's called PGTA, which is pre-implantation genetic testing for aneuploidy. And aneuploidy is just the nice way of saying abnormal number of chromosomes. Chromosome abnormalities are completely sporadic, and they're also the most common causes of miscarriages or failed transfers. So for somebody who's investing so much financially, physically, mentally, spiritually, emotionally, and time, investing something in IVF, this is also usually something that's done to screen embryos for risk factors that would just lead to a miscarriage, so that we're optimizing not only embryos that don't have a genetic mutation, but also ones that don't have risk factors that would have just resulted in a miscarriage. Moving on, this is just some questions that were sent to me in advance of more specific details on the IVF process or other things to consider with family planning and inherited arrhythmias. So the first question, who do I talk to about family planning options? I mentioned a few, actually probably a lot of different people. And there are a lot of people you should consider talking to about family planning. Certainly people like your primary care provider or an OBGYN, thinking about just the routine things in pregnancy or different birth control options, what's right for you. But I think maybe I should have put this at the top of the list. Your cardiologist would be very important to talk to. Getting clearance that pregnancy is safe, and again, we know that pregnancy is safe for most people with inherited arrhythmias. But just getting a conversation going with your cardiologist about what this looks like during pregnancy. How are you going to be monitored? A preconception consultation with a maternal fetal medicine specialist. Again, this is a high risk OB physician that's going to manage high risk pregnancies, whether that's a maternal risk factor or a fetal risk factor. They'll review other medications, your medications for inherited arrhythmias, but potentially any other medications, other underlying health conditions, and then make recommendations that will get sent back to a general OB provider to manage kind of the day-to-day pieces of a pregnancy. For people considering IVF, or if there's any sort of underlying infertility or people that maybe would consider using a gestational carrier or a surrogate, or same-sex couples, they might meet with a reproductive endocrinologist to guide that family planning. Urology, if there's male factor infertility, genetic counselors, specifically ones that specialize in reproductive genetics, to discuss options for genetic testing of embryos, carrier screening, what screening can be done during pregnancy, making a plan there. Other people might be your financial planner or a social worker, or of course, just your family, your partners, or other support networks as you think about growing a family. Why would somebody consider IVF? Well, IVF is an option for a lot of people. Specifically, we usually think about people who are experiencing infertility. So some of those common indicators might be age-related risk factors. I mentioned before, we know fertility and fecundability, which is the chance that somebody would conceive on each menstrual cycle. We know that those decrease with age. There's fewer eggs available, lower chances of success. So that can sometimes be a factor to say, well, let's expedite this process and pursue IVF. Issues with the fallopian tubes, if they're damaged, blocked, or missing. People who have ovulation issues, like irregular menstrual cycles or ovulation cycles. Other conditions, endometriosis, PCOS, low sperm count or quality. People who've been trying to conceive for over a year without success. These might be reasons to consider IVF. And then certainly elective for the purposes of genetic testing on embryos to avoid transferring an embryo with a genetic condition if they're hoping to reduce the risk that's passed on. For some people, they might not have chosen the elective version or the elective option. They wouldn't have done IVF otherwise, but they might have one of these other reasons, say, well, now we've reached this point of doing IVF, so maybe now we will consider PGTM, even though we maybe wouldn't have done it for the sole purposes of testing embryos. Since we're at this point, maybe we will consider that now. Do I need to know my genetic variant before I can have IVF? The short answer here is if the purpose of IVF is for testing embryos, then yes, you do need to know your variant before you can do anything with testing embryos. PGTM, again, the test is very specific. I mentioned before, there's a lot that goes into designing that probe. The other piece of this is when an embryo is tested, there's a biopsy that happens where only about 3 to 5 cells are removed from an embryo for genetic testing. And that's just a really limited amount of DNA. There's not enough DNA to do like a full panel, which sometimes people have as a part of their own testing if they don't know what gene they have a mutation in. They might have a panel of 10 or 20 or 50 genes that are looked at. And that just really isn't possible with embryo testing. So we do need to know the mutation in the family before we can test embryos. There's also some people who have a diagnosis of an inherited arrhythmia and even a strong family history of that, but we can't find the mutation. Maybe it's a gene we haven't discovered yet. And if we can't find it in the person who has that diagnosis themselves, we're not going to be able to find it in their embryos either. And so going through that whole process of IVF would not be a benefit to that person. It wouldn't avoid passing on that mutation. What does the process of IVF look like? It is a pretty detailed process. So this is a pretty simplified overview where there's some tests done ahead of time. The ovaries are stimulated through different medications. The eggs are retrieved from the ovaries. There's a sperm retrieval. Those are put together for fertilization and embryos created. And once that embryo grows for a little while, it's then transferred into the uterus. That is a very simplified look at it. It's actually way more complex than that. And I won't go through all of this, but everything in this orange circle here is actually just this first step, this tests and diagnosis. So there's really a lot that goes into that pre-IVF process before you even get to the point of the ovarian stimulation. Lots of different tests need to be done. lots of different people that somebody would meet with. And so it can be a really complex process, and unfortunately can take a long time to get all of those steps completed before you even get to the point of being cleared to start the ovarian stimulation process. For the embryo creation part of the IVF cycle, so kind of getting over to this IVF stimulation and egg retrieval part, there is a period of time of like suppressing the ovaries. That's usually through some oral contraception, followed by stimulation, which is, if you've heard of people doing IVF, this would be like the shots that they have to give themselves. And then there's a surgery that's done to retrieve the oocytes or the eggs, which is done under anesthesia, followed by insemination of those eggs, where one sperm is inserted into that egg cell. And then that would be a day 1 embryo. And those embryos then have to grow in culture for about 5 to 6 days until they reach what we call the blastocyst stage. A blastocyst is an embryo where it's probably a couple hundred cells, and you can actually see the outer layer of those embryos. We call it the trophectoderm. And those are cells that are destined to become the placenta. And then you have this inner cell mass, which are cells that are destined to become the fetus once that embryo is transferred. With the PGTM process, then, a small number of cells, again, about 3 to 5 cells, is removed from that trophectoderm layer, that future placenta layer. The embryos have to be frozen then, and then that biopsy sample is sent off to that genetic testing laboratory to test the embryos for that familial variant. And then the results come back to the IVF clinic probably in about two weeks. Once those results are received and the clinic knows that there is an embryo that is unaffected and does not have any chromosome abnormalities, the embryo transfer can then be scheduled. And this is where the embryo is delivered through a catheter into the uterus. There's blood pregnancy tests that are scheduled about 9 days after that transfer, and then several days after that. And then a confirmation of pregnancy ultrasound is around 3 to 4 weeks later. That leads to the next question. Well, how long is this all going to take? What I usually tell people is realistically expect it to take at least 6 to 12 months to do all of that. This pre-IVF workup and visits and, all those things probably at a minimum takes 2 to 3 months. But we also know that there is, scheduling conflicts and work schedules, and what if your IVF clinic isn't close to home and you have to travel for that? The PGTM process does add a little bit to this whole process. So, you have several months probably for the pre-IVF workup. The IVF stimulation itself is about 2 weeks. The embryo development process is another week. Test results are another 2 weeks on top of that. And then embryo transfer is probably another 1 to 2 months after you get the results. So, the PGTM process add some time onto this back end where we can't do an embryo transfer right away because we have to wait for the test results. But the other part that we recommend doing at the same time as this pre-IVF workup, or even before, is getting that test development process going. That process where DNA samples would be requested from the biological parents, but also potentially the grandparents, because that can take 8 to 12 weeks. That is recommended to be done before the egg retrieval even happens, so that there's no delay in being able to provide those test results. So again, the short answer being, it probably, if somebody's doing IVF with genetic testing, probably around the 6 to 12 month range before somebody even is like transferring an embryo. What are the risks of IVF to the embryo? Generally, IVF is considered a safe procedure. There are small risks that we could lose an embryo anytime you manipulate an embryo during that freezing process, the thawing process, or that biopsy. There's a small chance, maybe about a 1% chance that an embryo just doesn't survive one of those processes. We don't see any evidence that freezing or thawing or biopsying an embryo would like cause a birth defect or things like that. But it is a point where you could lose an embryo that would have otherwise been healthy. There's also a small risk of getting a false positive result. We hope to minimize that by that test development process, but there's also a possibility of getting a false positive result with that chromosome testing. And what that would mean is that there's a healthy embryo that was misdiagnosed, and then we lose that embryo because it just didn't get transferred. There's also risks of birth defects just in IVF alone. Any pregnancy actually has a risk of a birth defect. All pregnancies have around a 3 to 5% chance of a birth defect, but IVF or other fertility treatments increase that by about 1%. We also see increased risks of things like maternal hypertension or gestational diabetes, and a little bit higher rates of prematurity in IVF pregnancies as well. Again, that embryo biopsy, the genetic testing doesn't change those risks. So those are really risks associated with just IVF in general, not the PGTM piece of IVF. This is the $1 million question. How much is this all going to cost? And IVF is expensive, unfortunately. One round of IVF, it's going to vary based on the clinic, the location in the United States or elsewhere, and based on different medical conditions. But on average, in the United States, one round of IVF is between about $20,000 and $32,000 per cycle. This image here, it's actually a couple years old, so these numbers might even be a little bit out of date right now, but just showing different parts of the country: San Francisco, LA, New York, New Jersey, Chicago, Boston, Seattle, and Atlanta, and what that total estimated cost for one round of IVF is. The kicker here is that around half of patients who pursue IVF will actually need more than one round of IVF. And so that number might double or triple or quadruple depending on how many cycles, how many egg retrievals somebody would need. These numbers also don't include the cost of travel or time off work or other logistical pieces. And most IVF clinics are in larger cities. And so for people that maybe live in remote areas, there's a lot of travel involved with the consultations or procedures that are needed. And this number actually doesn't include the cost of PGTM. This is only the cost of IVF. And so when we think then about adding PGTM to this, it's probably another $5,000 to $10,000 on top of that number. The PGTM component, the cost is including, that biopsy that happens of the embryos, the actual genetic testing, that probe development, the shipping of the biopsy samples to the testing lab. This number really is going to be dependent on the number of embryos that are biopsied and tested. And in subsequent cycles, sometimes the full cost is not required. For example, for some labs, once that probe is developed, that fee would not be charged multiple times. It would just be charged as sort of like a one-time lifetime fee. But unfortunately, it does add up quite a bit. Does insurance usually cover IVF? The answer is sometimes. It's really variable. Every plan is different. So things to consider here would be, first of all, checking your insurance benefits. Are fertility treatments covered as a part of your insurance plan? What are your employer benefits? Some employers have different benefits that would cover fertility treatments or like fertility preservation, like egg freezing and things like that. I always recommend that people pay attention to their fertility and pregnancy benefits during open enrollment times, where you could maybe switch plans that you're on, or when you're starting a new job, kind of make sure you understand what kind of benefits you have there. If you can select like a different tier plan through an employer, for example, that might have better fertility coverages. and there are some states that actually have mandated insurance coverage for either some parts of IVF or other fertility treatments. So, this map is from a really wonderful website called Resolve, which is the National Infertility Association. There are certainly laws that are being proposed and hopefully changing. The state I live in, Minnesota, has had legislation to try to get this passed for the last couple of years. Unfortunately, it's not there yet, but this would be a good place to check if the state you live in is not one of these that has fertility coverage mandated through insurance providers. It could change, and that might be updated someday. Other resources here. So this picture is also from Resolve. So just different resources in navigating that insurance and financial aspect of everything. There are some scholarships and grants that people might qualify for based on different health conditions or income or military service or things like that. There is also this Baby Quest Foundation, as well as Fertility IQ. There's some good resources there for other grants, as well as low interest financing options. Some people do end up needing loans for this, but there are different groups that provide low interest loans for fertility treatment. Lots out there, but it certainly is a complex process and not a very straightforward answer, unfortunately. So in summary, there, a couple things I want you to take away from this is just start that family planning journey early and consider what options, if any, to grow your family align with your wishes and your values. How do you envision your future family? There are many beautiful ways to make a family, and each journey is unique, and some paths are straightforward and smooth sailing, and other paths may be longer or rockier than expected or take unexpected twists and turns. It might not be exactly what you planned for or you expected, but early planning and preparation can help you be as prepared as possible, especially if you encounter an unexpected journey as you navigate this process. And finally, engage with specialists who can help you navigate this path to parenthood. Who are the people that you trust in your care? Who would they refer you to in navigating those specialists that can walk this journey with you and this path is really, really important. It's important you feel comfortable with your care team, and identifying those people early on, again, even prior to pregnancy, can help you get to where you are hopefully going. I also left a link here for identifying a genetic counselor. My specialty here, find a genetic counselor at nsgc.org. If you are looking specifically for a genetic counselor that specializes in reproductive genetics to navigate some of these genetic testing pieces or IVF with pre-implantation genetic testing, this would be a good place to start. And you can filter by genetic counselors that see patients in person or via telehealth and are licensed in your state. So with that, if there are any questions, I'm certainly happy to take them now. And thanks again for inviting me to speak today.
Thank you very much, Laura. Very comprehensive and excellent presentation. So we really appreciate it. And I just noted in the chat feature that if you have any questions, feel free to type those into the chat now, and we will address those. And I love your owl graphic for questions.
It's a stock image. I can't take any sort of credit for it other than just finding it. So
okay, so we have one question here. Do you need to have a special collection kit for cord blood or request cord blood collection ahead of delivery?
Yes, so definitely having a plan in place for requesting cord blood is really important. So that the way we do it in our practice is if I see a patient I know is going to want cord blood collection at delivery, there's a special place in the chart that we put that note so that the labor and delivery team would see that and they know to coordinate that. I usually put my pager number there as well so that if there's questions that they have somebody that the labor and delivery team can contact. So the second part of that question is definitely yes, is making sure that that is communicated to the team that would be delivering the baby. As far as the kit, for most labs, the answer is probably going to be yes. We have a lab in house where I work at Mayo. We can do the testing in house, so we don't need a specific kit if we're sending it to our own lab. But if we were going to send it to a commercial laboratory outside of Mayo, then we probably would want a kit that that was available. You can request those, but also a good plug for meeting with a genetic counselor during pregnancy. Sometimes I get people who are like, well, I've already met with a genetic counselor. I know what the risk is. I don't really need to talk to them again. And then I get paged, somebody's in delivery and they need all of these things. So, some of it's like, I get that people know what that risk is to their baby, but it is important to have the person that would be coordinating that involved and meeting with a genetic counselor during the pregnancy so that they can get everything squared away for you as best as possible and request kits if they're needed.
Thank you, Laura. I think we'll thank you for your presentation and your time and volunteering
Sure,
tonight. We really appreciate it. And we will be
absolutely.
sending this out to all the registrants. If they were not able to join us tonight, they'll be able to join us on their own time. So thank you all for joining us tonight. We appreciate it and have a good rest of the evening. Thank you.